Welcome back to the Injury Podcast. I'm your host, Dr. Craig Selinger, chiropractic physician. Today, we're diving into one of the most misunderstood areas in an injury case, diagnostic imaging. If you've ever wondered, why was my x-ray normal, but I'm still having pain? Why does my MRI, what does it really mean? What's the difference between a disc bulge, a herniated disc, a protruding disc? Can an MRI miss an injury? When should a CT scan be ordered instead of an MRI? In this episode for you, we're joined today with Dr. Nasir Siddiqui, Chief Medical Officer for Acumen Diagnostic Group. Dr. Siddiqui has an incredible background. He's earned his undergraduate degree at Vanderbilt University, graduated from Case Western Medical School, completed multiple advanced fellowships, and later earned an MBA from the University of Chicago, and now serves as the Chief Medical Officer for one of the country's leading diagnostic imaging organizations. Today, we're going to discuss MRI reports. We're going to discuss different areas of imaging. We're going to discuss how radiologists evaluate injuries after a motor vehicle accident or falls, and also discuss common misperceptions about imaging, advanced MRI technology, concussion imaging, artificial intelligence in radiology, and the future of diagnostic imaging. Whether you're an attorney, physician, chiropractor, healthcare provider, or someone that has been injured and you want to learn more about injury, we're going to be shedding light on a lot of these topics today. So let's get started. Before we begin the podcast, I just want to let everyone know this is for educational purposes. This is the disclaimer that we have to talk about. This does not constitute medical advice. Please seek out your healthcare provider if you have questions about any of these issues that we discuss. And this does not constitute a doctor-patient relationship. Again, it is for educational purposes only, and it is not medical advice. So with that, let's begin. Welcome, Dr. Siddiqui, to the show. I really appreciate you joining me. I looked at your CV before, and between undergraduate, medical school, all these different fellowships, and an MBA at one of the best business schools in the country. I mean, when did you have time to sleep?
Yeah, no, I'm very lucky to have a very supportive wife who is here, who takes care of the kids and takes a lot of things off processor for me and allowed me bandwidth to do things that I thought were beneficial for society.
Awesome. Well, let's get in a little bit about the show that we're going to talk about. But first, a little bit about you. What made you become a doctor?
So I actually come from a family of physicians. From great-grandfather to grandfather to my dad, who's a practicing neurologist, just retired in Cincinnati, siblings who are also in medical field. So it was almost not really a choice. It was almost, I felt like, hey, this is kind of what, as a Siddiqui, we do.
Wow, that's awesome. And why did you pick radiology as?
So in undergrad, I was a biomedical engineer, and I was fascinated by kind of the human mechanics. And what excited me about radiology was the visibility in those musculoskeletal injuries, but also what is going on in the human body and being able to see it with tools.
Right. Actually, let's get into what is a radiologist and what do they do?
Yeah, so radiology is kind of two big fields, diagnostic radiology and interventional radiology. Diagnostic radiology is the interpretation of imaging modalities, X-ray, CT, ultrasound, mammography, MRI, PET-CT are all within the domain of diagnostic radiology, where they look at the images and interpret them and provide a report for the patient. Interventional radiology is taking that image and using it to guide procedures.
Great. I actually myself had a liver biopsy way back, and it was a radiologist that actually did the study. They had put me into a CT scan, and they had put these little markers on my ribs, and that gave them they then were able to do the procedure, which was very interesting because before that I didn't think that radiologists actually would be doing procedures like that.
Yeah.
So that was interesting. So let's we.
Right, they used to do those blind.
I know.
I was just like,
I know. And why don't they do them blind?
yeah, because of complication.
That's right. Because somebody could die.
Yeah,
So I think it's important for people to understand that technology and better ways to do things and treat patients is, I think, at the forefront of medicine. I think physicians and hospitals are always looking for better ways to get better outcomes. That's just one example of somebody using guides to be able to do a procedure without causing harm, right? Above all, do no harm. So with that, though, we have a lot of our people that listen to the show are in accidents or trauma, or they're providers, or they're medical. They have a interest medical legal aspect of this. In a accident or trauma type of case where somebody's been in a car accident, what would be the first type of diagnostic imaging that usually would be done if somebody goes to a hospital?
Yeah, and the first line modality is X-ray. The intention behind X-ray is to identify alignment of the spine, any fracture that may need emergent treatment. Subsequently, based off of the X-ray and then the clinical symptomatology, the hospital, ER, immediate care would determine whether or not additional imaging would be needed. Right. On an emergent basis, that would typically be a CT scan. Again, CT, similar to X-ray beams, CT is done in a 3D fashion that allows you to get more visibility of the spine and the spinal processes and identify more subtle fractures if there's a concern for that clinically.
Right. So I've seen this a lot, and a lot of patients come to me and they don't know the difference between a CT scan, which is also called a CAT scan, correct, and an MRI. What are the differences between the two?
Yeah, absolutely. So a CT is a X-ray beam. It's radiation, and it's individuals on a table and go through the donut, the gantry, and it looks very similar to an MR, but that donut has an X-ray beam that goes around in a circle that creates that 3D visualization of the patient. MRI uses highly powerful magnets that align protons in the body and allow you to generate an image. And so it has no radiation, but it's really good at looking at soft tissue. So think CT, great for bone. MRI, great for soft tissues.
Wow, great. That's the next question I was going to ask. So why would somebody order a CT scan versus an MRI? And you answered it. Thank you very much. You beat me to it. So there is also, I've seen patients get MRIs and CT scans with contrast. And sometimes patients don't know about that. And what would be the benefit of contrast in either an MRI or CT scan?
Yeah, in a traumatic setting, when you're doing contrast, it's usually done emergently to look at vascular injury. Later on in the disease process, there's less utility for contrast. I think the misnomer for patients is, contrast is not always better. It's not always needed. It's what is the clinical question and what tool do we need to answer that clinical question?
Right. So it could be helpful in better seeing or revealing certain pathologies, sometimes the contrast versus other.
Absolutely.
Okay.
When you're looking for, in a setting of trauma, looking for a vascular injury, if you've had surgery before, looking at scar tissue, looking for infection. If you have a lesion, is it a mass? Being able to look at the enhancement characteristics allows you to have a better differential diagnosis of what that could possibly be.
Great. Awesome. Thank you very much. And now there are different kinds of MRIs, vastly, and some are open. People I get in my office, sometimes they're afraid of getting into a small space. So there are ones that are larger, correct?
That is correct. You have open MRIs, which give patients kind of more flexibility. There's upright MRIs, which allow for dynamic motion and imaging individuals in kind of a physiologic seated position, so you can look at axial load. And then there are high field MRIs, and these are typically the closed magnets where you lay on a gantry and you're able to get higher resolution images.
Right. So which is better? High resolution, closed, or open?
Oh, it's the question that you're answering. In a open magnet, upright magnet, you can do flexion and extension views, and that may be a question that you have clinically that needs to be answered. So there's not one right choice. It really depends on what the clinical concern is. Right. And then certainly what's the capability of the patient. We have an epidemic of obesity in this country where being in a closed magnet is very difficult, and an open magnet is the only choice that you have.
Right. Okay, great. Now, you mentioned something just before. I want to unpack that. You said flexion extension. So for the viewers out there, if you don't understand what flexion is when you might be bending your head forward or bending forward, and then extension is coming backward. So I know that many chiropractors and physicians refer patients out for MRI after an accident or trauma. And if it's to the spine, the neck, or the back, they might be concerned if there's a herniated disc or some other type of pathology that could be present. Now, besides a herniated disc or an injury to the disc, what other common findings are there from MRI, and what other types of MRI are there that can show maybe injuries that you wouldn't see on a traditional MRI scan?
Yeah, no, absolutely. So for MRI, you're looking for the disc bulge, but you're also looking for other soft tissue injuries. You can look at muscle sprain, strain, edema within the bone, which is a marker of injury to the trabecular of the vertebral body and wouldn't be visible on a traditional CT. Also looking at underlying physiologic changes that have happened that you can elicit with flexion and extension. A lot of it relies on the clinical symptomatology, but if you see a patient who only has symptoms on extension, you're able to see that with MR when you're mimicking that right. On the scanner.
And that's really important, because as clinicians, many times patients don't have pain all the time. They might have pain, doctor, I have pain when I'm bending forward. But when I'm sitting here now, I don't have any pain, or when I'm standing, I don't have any pain. When I look this way and down, I get pain. Otherwise, I really don't have much. So sometimes an MRI that is just static, meaning the patient is not in a stress, they're not moving their head in any way or staying in a different position, can be very, very effective at showing not only a herniated disc, but other injuries to ligaments that can be the reason why the patient's having pain, why they might have instability in a certain area. Is that correct?
That is absolutely correct. MRI, you have, as I kind of talked about, you have different types of MRIs. With the lower field and the upright MRI with deflection extension, you can look at the alar ligament, which is the ligament at the craniocervical junction, and you can see subtle abnormalities with that. With the higher field MRIs, you get higher resolution, and so you can have a more detailed look at the ligaments. And these are tiny, 2-3 millimeter structures that you're able to have visibility of, and it's a very subtle finding.
So the lower field can be like an iPhone 10, and then, or maybe a 5, and then the high field or the closed can be like an iPhone 16 or something
I
like
think that's
that
a
with
good,
better.
good analogy. It's a good analogy that if you're talking specifically resolution, there's no doubt that the higher field provides better resolution, and it's physics, and you can't argue with the physics.
Right. Excellent. So it's also important to note that at the center that you are the chief medical officer for, here we're recording this in South Florida, you have many centers that do provide this type of diagnostic imaging where the head could be in a forward position or a backward position, and you can actually do that kind of study where some MRIs you might not be able to do that. Is that correct?
That is correct.
Okay, so that's definitely an important thing to note, because some patients might have a negative MRI, meaning they don't have a herniated disc, but they still have a lot of pain. So being able to go that extra step and find the area that is injured through more appropriate diagnostics is key. And that's what we are about, because to me, I feel that I've given a patient a disservice if I don't go above and beyond, look under every stone, and make sure that we're trying to really find the root cause of their pain drivers, what's really causing the pain and disability for this patient. And if you don't have the right imaging, you might not be able to find that. And that's important, especially if somebody's been in some kind of accident that maybe wasn't their fault, and now they have some kind of injury that might take a long time to heal or might not heal fully. So it's important to use the latest technology to find those injuries for patients, so we as providers can do treatment that's appropriate, one. Two, we can also understand for the patient, they can understand really what's going on, not make it worse, not do certain activities that are going to make that injury worse. So I think it's really important. I'm an advocate of that. So let's talk about MRI and herniated discs, a bulging disc. A lot of people have seen on MRI reports a bulging disc, protruding disc, herniated disc. Can we use the model there, Doc, and show us where the disc is, one, so people know, and then two, the different use of language that's being used in these reports, so you understand, or a patient can understand, what the differences are, because we all don't want to rely just on Google or Dr. Google and look things up and try to interpret our own MRI or ChatGPT or Claude or so forth. We want to have from an expert radiologist give us some guidance on those proper use of words.
Yeah, no, absolutely. And I would highly recommend deferring to your medical expert and not do it yourself.
Or Dr. ChatGPT.
Dr. ChatGPT can be wrong and not provide the full context. So when we're talking about disc pathology, there are probably four main terminologies that I'd like to go over. The broad-based disc bulge, and think of it like a hamburger, right? And the burger meat, as you push out, you get this diffuse bulging of the disc out, and that's what they mean by a diffuse disc bulge.
Okay.
Herniation is a focal disc bulge, and so that means it's a focal area that pushes out of the disc. And you can see if I'm pushing to the right here on that right corner, the disc comes out. And there are two terminologies with herniation: protrusion, which means that the base, what is being pushed out, is smaller than the base of the herniated disc, and extrusion, where the hole, what is pushed out, is bigger than the hole. So think about it like toothpaste coming out of a tube, and you've pushed it out.
Okay. All right. So let's unpack this a little bit. So a bulge would be just a broad area in the disc that is moving out further because of inflammation possibly, or other tearing of certain structures inside the disc that are allowing the disc to shift over to the side.
Correct.
Or backwards or to the front, wherever that weakest point is, and depending on many factors. And a herniated disc would be when a part of a more smaller part in the disc comes out or protrudes outward. I don't even want to use that word protrude because that's used a lot. And then that will come out further, and it's not really it's not broad. It's more in a very small area.
Small area, very local area, and the disc around the disc is a very tough fiber called the annulus. And a defect in the annulus is where that disc is pushing out of. And so think of it as that defect of where you're getting that herniation of the disc.
Yeah, and then an extrusion would be when that herniation becomes worse and more material or more, whether it's the material inside the nucleus pulposus or other material or inflamed, or there's more inflammation, and that is actually going out, and it's larger than the base where that is.
Base, yeah, really like that toothpaste. You're squeezing on the toothpaste, and the bulge comes out, and you see it in MRI as kind of the bulge extending from the disc space into the spinal canal.
Right. And then there's another term I've heard, which isn't as common, called the sequestered disc, where that piece breaks off, correct?
That is correct.
So that is much worse because that can lead to putting pressure on structures, whether it be in the spinal cord or spinal canal or other nerve roots, and it's not tethered to the part of the disc, so it can float around, and it might cause even more inflammation and more damage.
Yep.
Okay, so and all of this is again, it's a case by case basis. Everybody's situation is different. I don't know your particular situation, so again, this is not medical advice. We're just educating people on the differences of the nomenclature of how there's a description for the injury. I've heard also protruded disc versus herniated disc. Are they one and the same?
Protrusion is a type of a herniated disc. It's that protrusion being the base being bigger than what is being pushed out.
Okay.
As opposed to the extrusion, which I also constitute a herniated disc, but it's a specific type of herniated disc.
So if we're going in order now, bulging disc, the least bad, right? The next would be protruding disc.
Protruding disc.
Okay. The next level would be herniated disc.
Extrusion.
Yeah, extrusion. And then sequestration. So is a herniated disc just another word, another term for extrusion? Extruded disc?
For protrusion and extrusion.
Okay. Yeah. All right. So those can be used kind of interchangeable. Okay. Because I know that this comes up a lot, and sometimes it can be confusing for people. So especially for chiropractors too. So I wanted to shed some light on that. Now, thank you for doing that. The next thing I wanted to discuss, often patients they might have arthritis or degeneration or wear and tear in their neck or back that's being imaged. And sometimes there are insurance companies that will say, well, this is all a prior injury. Are there ways that radiologists can tell on an MRI scan whether it is a more acute injury or whether it is a more chronic injury?
Yeah. No, I think the point there is, and we were talking before the podcast, that 30% of patients above the age of 20 have some degenerative changes. And so as you get older, that percentage goes higher. So there is going to be degenerative changes within the spine. The role of the radiologist is to look for acute on the underlying chronic conditions. And there are multiple tools. The biggest one is edema. Any kind of fluid signal within the spine is an indication of a acute process happening, whether that edema is within the bone marrow or within the facet joints as an effusion, or even at the annulus, where you can have a tiny amount of fluid, which is indicative of a tear of the annulus.
Okay. Now, let's say somebody has a car accident on July 1st, and then they get an MRI 5 months later. Would a radiologist be able to tell as much from that scan if it was acute versus chronic? Or would it be better to see those changes, those acute changes, if they had an MRI 3 weeks out?
You'd make my life very difficult if we got the scan done 5 months later. I mean, that as soon as the injury happens, that is kind of the best time to image. The closer to that allows us to see any internal derangement in the acute phase.
Right. So that's important because there are some, I've even heard this, and not so much in personal injury work, but in insurance, working with commercial insurance carriers out there that are not injury related. The big insurance companies like Aetna, Blue Cross, Cigna, those many times they have providers have to go through a series of different steps. They might have to have a patient take medication before an MRI. They might have to do a little bit of PT before an MRI, and then they can maybe go for the MRI much later down the road. So in that case, sometimes it might be difficult to see some of those changes, but that's just a thing to say. So,
but it is there, and I wouldn't say not to do the MRI if some time has passed. There are mechanisms where we can look at age of injury and be able to provide a assessment of when that pathology happened.
So within a month of the accident, would many of those acute inflammatory markers be still present? Typically?
Yes.
Okay, so within a month period of time. That's typically when I see patients and treated patients, that's usually what we'll look at, and we'll use our clinical guidelines to make those recommendations before we do order any test, which is important. All right, let's go into concussion, which is also known as traumatic brain injury, TBI. Some of you out there have heard about this. It was always around, but I think the technology is getting better at being able to image these kind of injuries, because concussion or TBI, for the ones that are more mild, are very difficult to find objective tests, meaning tests that you can actually see the results of that injury. You could see those injuries. What are some of the imaging studies that could be relevant to diagnosing a traumatic brain injury, ones that are a little bit more mild in nature?
Well, I think the way you framed spine injury is probably a good way to go through concussion, and going through that pathway of the emergent concussion when you show up to the ER or the immediate care. What is their first modality? And that's typically a head CT. And the hope with the head CT is identifying any major pathology, a calvarial fracture, a skull fracture, any bleeding in the brain, whether it's a subdural, epidural, or intracranial hemorrhage. And then after those processes are ruled out, then you know that there's not anything emergent that needs to be done. If the patient remains symptomatic, then you worry about a concussion. And that's where the brain MRI comes in. And I think you articulated it really well. The field has evolved significantly. What we were doing 3 to 5 years ago is different than what the standard of care is now. And we have so many more tools to be able to look at the brain.
Okay. So when somebody goes to a hospital and they've been in an accident or a fall or something, some traumatic event, many times the hospital, in terms of, as what I'm aware, is they're interested in making sure the patient's stable, that the patient's not going to die. They're interested in knowing if there is a skull fracture. They're interested in knowing if there's a brain bleed, and they want to rule those things out immediately because that they might have to use take life-saving measures in that moment to save the patient.
That's absolutely correct. It's triage. And the imaging modalities that they utilize in the ER are meant to triage the patient, whether a emergent intervention needs to happen or if the patient can go safely home and follow up with their primary care physician, neurologist, to get additional treatment.
Yeah, it's important. So at Acumen, and especially down in South Florida, what are some of the different types of studies, techniques, I guess, that imaging that a provider can use to be able to diagnose or any kind of brain injury?
Yeah, it's a great question. So they're similar to the toolbox analogy. You have a slew of tools within at your disposal. You have your standard brain MRI, but then you also have a concussion protocol where you are looking at microbleeds in the brain. There is a technique called susceptibility weighted imaging, or SWI, which amplifies hemosiderin deposition within the brain or hemorrhage and allows it to bloom and becomes far more sensitive for the radiologist to see. Adding to that, when you're getting further into traumatic brain injury, there's DTI, which is diffusion tractography imaging, where you're looking at the white matter tracts, and any subtle disruption of those could indicate a traumatic brain injury.
Right. Okay. And there is also, I've heard patients say, I went to the hospital, I had a CT scan, and they said it was negative. How can I have a concussion? So this sheds light that just because one imaging study is negative, it might be looking for something different, and it might not be sensitive to these changes in the brain, where if you did a regular MRI of the brain and you didn't have that type of technique, you might not be able to see and image that. And then it doesn't mean that the patient might not have it. It might mean that the test that was done didn't find in that particular imaging set. But that doesn't necessarily mean that the patient doesn't have it. They might not have had the right test for their condition.
Yeah, and I think these imaging modalities rule in the disease process and limit the differential diagnosis. They do not exclude the possibility of having a injury. In taking a step further, there are other volumetric tools that we use now with brain volume, looking at the sequela of traumatic brain injury 3, 6, 9 months out, where you're looking at the volume of the brain compared to a normal brain, and you can tell, hey, this was a traumatic brain injury, and we're seeing the later effects of it by a decrease in brain volume.
So let's unpack that a little bit. So if somebody has a brain injury, they can have a series of MRIs looking for changes in size of the brain, right? And then also being able to see if these other inflammatory effects of this injury are getting worse, or what other changes are present. So it's not just a one-off MRI, because that might not be good enough to actually really show the effects of that injury.
Yeah, the long-term damage, the sequela of kind of the axonal injury or brain trauma, what those effects are. And I love how we're always bringing this back to the clinical question, because imaging is one piece of the equation. The clinical history is paramount, the mechanism of action, and then the clinical examination, and then the imaging helps round that up. Right. And I like to think of it as a a four-legged stool of you have the clinical history, the mechanism of action, the clinical correlation or assessment, and then imaging. And without one of the legs, it's a wobbly stool.
Yeah, very important. So it both the clinical findings and the imaging go hand in hand to help give the patient the most accurate diagnosis, because sometimes imaging is not it's not able to diagnose it completely, and then sometimes the history that the doctor takes and the exam isn't able to pinpoint where those injuries are. So they work together, they complement each other. So now I know that with AI here, we talked a little bit about Dr. ChatGPT before, and Dr. Google and Dr. Claude, that there are changes happening in radiology with artificial intelligence. What are some of those changes, and what are you hopeful about in the future?
Yeah, we're using AI actively within our practices. A lot of it is done for image enhancement, of making images crisper, decreasing the time that patient's on the table so that there's not motion degradation, and making it a more comfortable exam for the patient. I think the ultimate hope of AI is that providing that additional set of eyes or AI to create the scaffolding to make the work more accurate for the radiologist, give them the tools to be able to be more effective at what they do. A lot of optimism there. I think there's a lot of potential. Radiology is a space where they say 75% of FDA approved AI applications are in radiology. I think over 1,300 right now are FDA approved, but a lot of them are not. None of them are autonomous. They are a supplemental support tool for radiologists or radiology care to allow us to provide more efficient, more accurate diagnosis.
Will AI replace radiologists?
It's a good question. I think what you can say immediately is radiologists who don't use AI will be replaced by radiologists who do use AI.
Oh, that's great. That's great. So as a tool to help the radiologist and not a substitute, which is important. Is there anything else about the type of studies or equipment that Acumen has in South Florida that we want our listeners to learn a little bit more about?
I think with Acumen, we have a multimodality platform, and that's from X-ray, ultrasound, MRI, CT, PET-CT, so that you're able to use the full toolkit available in the diagnostic spectrum to identify and help treat your patient. And I think you will see that often in our reports, the reliance on clinical correlation. And clinical correlation is not a hedge by the radiologist, it's an invitation to the clinician to look at what we're seeing and correlating it with what you're finding clinically. Because sometimes it matches up, and then you have you have matched data points,
Right.
but sometimes they're divergent, and you have to
Right.
identify why there is a discordance.
Right. And then also, sometimes you might have to go back for different imaging because one image was negative, but the patient's still having pain, and then you can order something else that might be better to see what it can be, because there's not just one magic bullet for this is one test you do and it discovers everything that's wrong. So there are differences. It's important as clinicians that that we do a great exam, take a proper history, and then from there go through a very good set of protocols before ordering these tests, and then do the tests and keep looking for that patient, because that's what's really important here. The patient, we want to be able to help them and figure out what's wrong. That's the core. And I think when I think of radiologists, I think they're the people that really help us figure out what's wrong with a patient. And if you know what's wrong, you could then, in many cases, give the right treatment to get the patient better. If you don't know what's wrong, it's very difficult to recommend the right treatment for that patient. Dr. Siddiqui, this has been a great episode. I really thank you for coming here. But before we are finished with the episode today, we have a little ritual here. We give away superhero tumblers. Now, behind you here, we have Captain America, Wonder Woman, Batman, Deadpool, Thor, Spider-Man. I have a Hulk one. It's not here in studio, but we do have that as well. And the reason why we do this is because these represent comeback, resiliency. They are individuals that have a power. And I feel that the guests I have on, their superpower is it could be radiology. It's something that helps that make a difference in that patient's life out there, helping them get better, discover something new, and let's help people get better. So which one of these tumblers speaks to you the most? Yeah.
Craig, I think I'm going with Thor.
Awesome,
and it's,
awesome.
You know, it's the power of imaging, the power of that magnet, and then the growth and innovation that we're seeing in the field. And then ultimately the humility of, you know, a negative MRI sometimes doesn't explain the symptoms, but the patient may still have something going on.
Right, right. Well, that's a great note to end on. Knowledge is power, and you have to be able to understand the patient from many different facets, whether it's being in the exam room with the patient, and then also very important imaging studies, diagnostics, to be able to link that together with your clinical findings in the office to be able to come up with a better treatment protocol for the patient and let them know what's wrong. So again, thank you for coming in today. I really feel honored for you being here. And again, thank you for tuning in. And if you are interested in learning more about injury prevention, latest information from different experts in the field, physicians, please subscribe, follow the channel. Thank you again, and have a great day.